All right, so welcome everybody. Tonight I wanted to go over a clinical situation that popped up today. I think it's going to be very applicable to everybody's clinical treatment planning prowess, but more importantly, just kind of decision making when we look at tough clinical cases. So let me switch to my screen. While I'm switching over, I'm proud to announce that the Maine AGD has endorsed vote on number 2 in Massachusetts. So we got the group to donate $1,200 for the cause, which was nice. Hey Chad, you want to chime in? Let me know if you can see this.
Yep.
All right. So NECADE 2022, a common clinical quandary. Really, all clinical scenarios are quandaries in some form or another. But before we get started with that, let's take a look at a few tidbits. As always, if you want to get a CE credit for tonight's hour, your camera needs to be on. This is not my dictatorship ruling what you do and don't do. This is PACE accreditation guidelines. Maine AGD, as we talked about, will be endorsing vote yes on number 2. The Massachusetts Dental Insurance Referendum, which we've been talking about over the past several weeks. If you haven't called your friends and family in Massachusetts, please do so. I thought it would be helpful. I get lots of questions from you guys. I have questions for myself. I have questions for my mentors. We learn through questions. We learn through struggles. I just wanted to share some questions that I get throughout the week to help everybody understand that, one, there are no dumb questions, and two, questions are always popping up in our clinical operatories. So patient gets a night guard and now they have loose teeth. We're not going to go down the road today. I think this might be a good future NECADE session, but what's going on here? Patient doesn't have loose teeth. We give them a night guard and they get loose teeth. Obviously, a lot we could unravel there. Another common question, is there anything other than Teflon tape for implant access holes? Yeah, lots of different things. Teflon tape can be rather cumbersome when we have to remove it. So this is a common question. I will quickly say I've started using PVS, but I actually read a paper recently saying that PVS light body over time becomes very brittle. So we're going to be looking for another solution here. There's a couple companies with some products that can help us with this. But this is the kind of questions that come up. Are there any openings left for New England Master Track program? That was a question I put there as an advocation for you guys to realize that there are there's 2 spots left for this current track. Conversation came up about CEREC. Is CEREC always the answer? And I think the answer is no, CEREC is not always the answer. I think it's a good tool in the right practice. Obviously, I don't think our practice is the right practice for this kind of equipment at this point in time. With that said, these are the kinds of questions that can pop up. Biodentin, what the heck is this stuff? What can it be used for? We had a perforation during an endo access at the office. Biodentin is a great tool to repair iatrogenic perforations if the repair is done at the same appointment as the perforation is made. But Biodentin can also be used for pulpotomies. So there was another question that came up in that arena. So Biodentin is a tool that I think we should be aware of. We're going to spend some time on that product in the future, but I would encourage everybody to go to the website. Septodont is the company that makes Biodentin, and learn more about it. And then lastly, how do I get involved in organized dentistry? This is something I've advocated for people at the right time in their career. You know, there's lots of moving parts in our personal lives and our professional lives. So I don't say this as an expectation of anybody that I know, but I just want to extend the offer that I would be happy to help somebody if they want to get into organized dentistry. I bring this up specifically because I have 6 months left as president of the Maine AGD, and one of the last things I want to do is bring in some young blood, some new fresh faces, new fresh perspectives on bringing the Maine AGD into the next decade or so. So if you're interested, please reach out. All right, to the fun stuff. So here we have a patient of Chad's. Chad and I have talked about this case, what seems like for a couple months now. We did talk about this on one of the recent NECADE treatment planning sessions. But I didn't want to go over the comprehensive treatment plan. I wanted to go over how do we solve this area in the front for two reasons. One, I think it's good for us to learn how to treatment plan isolated areas. Not every patient necessarily wants a full mouth rehab. Not every patient can afford it. This particular patient, I think, can afford it, maybe doesn't. He seems like a kind of a free spirit individual. He's not in a ton of pain. He just wants to get his front tooth fixed. More or less, he's on board for kind of chipping away at the other problems. But what I want to do with this case now is say, what if the patient just wants to deal with the front? How do we solve this? This is a common clinical scenario. So what's our problem list? Just very quick problem list. Deep bite. Whenever we have deep bites, especially where we have loss of posterior support, we definitely want to have a conversation about how does that deep bite play a role in the prognosis of their natural teeth, but also of the dental treatment that we're about ready to do. I see Dr. Hicks is on the call today. He did a case on a veteran who kind of presented with a similar scenario. I'm really hoping that Dr. Hicks will show that case because it's an absolutely fabulous execution for a situation that started like this and a full mouth rehab solution to solve an anterior problem. But the point is, these are common. When we lose posterior support and we have a deep bite, there's a lot of stress considerations to consider. When I look at this kind of situation, I always come back to the following. If I'm going to build something here, I need to consider the environment. This is a hostile environment. This is like building a wooden house on a fault line, the San Andreas fault line in California, or building a very weak house in Tornado Alley. We have to consider what we're going to build in a patient of a mouth like this. And at least for me, I wasn't taught to think this way. I was taught to solve all problems as if the environment surrounding the situation were the same. We all know that if this patient had an anterior open bite, our problem solving or our solution list would probably be somewhat different. But this patient has a hostile environment, so how do we treatment plan this? Well, let's continue taking a look at the problems. Missing teeth, we talked about that. Loss of posterior support. We have some generalized recession. Recession tells us that there's most likely strong occlusal forces that are destabilizing the periodontium around the teeth. Crowded teeth, always a problem. Anybody want to throw out any other obvious problems here? Again, we're going to spend less time about the comprehensive treatment plan, but is there anything else obvious here? So we talked about the concept of a stiletto heel. Can anybody point out a problem that they see with that small hint?
Not sure I'm getting the reference. I don't remember that part of the conversation, but number 10 is flared out. I remember talking about that.
Yep, so number 10 being flared, what might that tell us?
That there's an airway problem?
Yeah. Anytime we see splaying of teeth or accentuated buccalization of teeth, we always have to ask ourselves the question, is there an airway problem? Well, where does the splaying come from? It's typically due to periodontal breakdown combined with tongue thrust. So that's definitely something we want to take a look at. Anything else that we see here? So the stiletto heel concept somewhere in my CE journeys came up. The concept is the following. If you were to get kicked by an old lady, do you want to get kicked with an old lady with sneakers or a stiletto heel? Obviously not the stiletto heel. The point is, this particular lower arrangement with a deep bite where you have a tooth that's sitting more buccal, or a portion of a lower incisor that's sitting more buccal than the other teeth, that will act almost like a stiletto heel up against the opposing tooth. Whenever you see a missing tooth that is root canal treated in the maxillary anterior, look below, you're often going to see this. So I bring this up because it's a good thing to understand, because it causes lots of problems. But two, if you're going to build something here, you have to take into account the fact that this is still there. I wouldn't want to restore this tooth. If we were going to somehow restore this tooth, I would not want to restore a compromised tooth if that was still present. I'm not advocating we restore this tooth, but I'm much more likely to restore this tooth if it's a poor prognosis or a guarded prognosis, if we get rid of this guy through ortho, enamelplasty, veneers, what have you. So what's the opposite of the stiletto heel? It's the sneaker. And essentially that's an occlusion where anterior guidance will be spread out across the anterior segment of the mouth. So this is a high stress area because the surface area is very small. The muscles don't really, well, they kind of do know through proprioception, but some muscles don't really care to turn off through proprioceptive feedback of an isolated area. We're kind of going down the nathology road. The point is, this is important. So I just wanted to bring this up, that when we treatment plan this particular case, we have to take that into account. Any thoughts or questions on that?
How much can you enamelplasty without causing more issues?
So Spear talked about this. He has a pretty good module where he discusses this. There is no literature to support one way or the other how much you can do. The takeaway message is, in patients who have wear, you can take away a lot, because patients who have wear have more tertiary dentin buildup in their pulp chamber. So you really can get rather aggressive with these kinds of patients that have this particular scenario. The answer is often aided by the radiograph or the CAT scan. So you essentially look at the pulp and see, how much available tooth structure you have. Oftentimes you're taking dentin away. But what I would say is, if you take away too much, you can always add a cap of composite on top of it. I'm always of the line of reasoning that taking away tooth structure to achieve a greater good systemically is always better than, quote unquote, being conservative of tooth structure. That's a pretty common misconception, at least from my perspective. I think most of the people on this call know how I feel about that. I don't mind sacrificing teeth sometimes to achieve a greater systemic end, because we know what happens when the system is out of whack. The teeth will deselect themselves anyways, so why not be in control of that and then end up with a stable situation? So I'd be okay being rather aggressive here with the enamelplasty, knowing that I'm creating a more favorable system. Now what we could do, and a few of us have done this recently, is do a little bit of enamelplasty but balance the occlusion by adding composite to number 23. So getting rid of the difference between these two by adding some composite here to help maximize the surface area upon protrusion. So yeah, good question, Chad. All right, so here's the PA. A lot we're going to unpack on this PA alone. But let's continue with our problem list using this particular PA. I think we can agree number 9 is hopeless. I would like to say there's definitely a possibility with it, maybe a cast post and core, some crown lengthening, where we could save this tooth. I've definitely saved teeth like this before with long-term predictability, or I'd say somewhat long-term. I definitely have teeth like this that are pushing 8-9 years at this point. The problem with this particular tooth, and we can't really appreciate it on this, there's a rather large abscess coincided by this root is actually sticking out the buccal plate of the alveolus. So the tooth in and of itself, I wouldn't say is hopeless, but the surrounding bone structure is. So we're going to call number 9 hopeless. We could definitely have a conversation about saving it, topic for another day. Large periapical radiolucency on number 9, as evidenced on the CAT scan. So we have some bone loss, some crestal bone loss around number 8. Now, is that bad? We'll talk about that in a moment. I think there are times when this is bad, but there are times when it's inconsequential. So here's the in order to come up with the treatment plan, we had to identify what kind of implant this was. And I think we'll gain some sense on why we had to know what kind of implant this is in order to solve the problem. Let me take a step back. We want to solve the problem of number 9, but we need to know the implant specifics of number 8. That's really kind of where I'm heading with this. So how do we find implant identification? So you get this PA, let's say you didn't place the implant. How do you find out what implant that is so that you can order parts and tools in order to do stuff with it? Most obvious is to obtain the records from the previous providers. The more and more time goes on, the more we hear the provider is no longer in practice, we can't find their records. We have now converted all of our records to digital, and we burnt all of the records, and we've heard it all. This happens all the time. It's going to happen more and more as the ages of the implants in patients' mouths become older in respect to when they were placed. So we have to have some sort of method to find this information that doesn't involve obtaining the patient's records from their previous providers. If you have a hunch, you can contact the implant representatives. Your local rep can help. They're really good. This is what they do on a daily basis, or calling the company and sending them an image is helpful. Many of us have heard about the website whatimplantisThat.com. I haven't found this overly helpful. In great part, you need to know how to describe different implant geometries. Unless you've been doing a lot of implants, that's not something that the average young dentist has in their skill set. I think we should all get there, but it's really not that helpful unless you really understand what a tapered implant is. That's an obvious one, but tapered implant, is there a vent, apical vent? What kind of thread design are they? Buttress threads versus V-shaped threads. What kind of platform? I mean, these are somewhat advanced questions, at least for the younger doc. So I haven't found this to be super helpful, even with what I would consider many years of implant experience. I have not found this to be helpful all of the time. Fortunately, we have a solution now, which several of you guys have done and gotten great information. Preet is a company in California that is becoming the preeminent leader in the graveyard of implant prosthetics. So all of these companies that used to be around, that no longer have implant prosthetics, Preet has found that market niche to be extremely important, and they filled that hole. Well, what they can do for us is actually identifying implants off PAs. So that's the company there. Chad, you want to share how you went about? So did you send an email to them, or did you go to their website?
I downloaded the app
Yeah.
and did it through that. The app, when I was kind of messing around with it, didn't seem like the greatest. It kind of crashed a few times, but it allowed me to do my submission, which was the important part. So
Yeah.
I think I got a reply in 30 minutes.
Yep. Yeah, I've always gotten replies within, they say 24 hours, but it's typically during the work week. It's been rather quick.
Yeah.
I normally just go to their website and upload it because I'm normally at the office, and I'm not that agile with my phone. So I typically just have Tessa do it. It's really the answer to that. So it's been great, and they'll send you ideas or thoughts. They'll send you how confident they are, and then they'll help you with procuring the particular tools that you need to use to solve the situation. So through the help of the the Preet company, we determined this was a Nobel active implant. Chad, I can appreciate I'm kind of bending the story a little bit, but for purposes of the story, we determined it was a Nobel active implant, which is correct. I'm very familiar with this implant because I've placed many of them. But the next question was platform determination. This was a tough one. So Nobel active is the particular model implant. Nobel is the company. But the platform itself dictates what kind of prosthetic tools you're going to use. So we had to determine, is this a narrow platform, regular platform, wide platform? Some companies call the platforms or indicate their platforms based upon millimeters. For example, BioHorizons, which is what we use, has the 3.0, the 3.5, so on and so forth. So what Preet said, they weren't very sure about the platform size. Chad and I spent some time on the CAT scan, some time with this PA. I sent this image to the Nobel rep. I have his phone number. He wasn't even sure. He had an idea. I kind of walked through this, and I just want to share with everybody the problem solving that I used in order to figure this out. Before I do that, does anybody want to shed any light? Maybe there's a quicker way to find out, is this a narrow platform or a regular platform? I hear somebody chiming in.
My only thought was to try to use the radiograph measuring tool on the radiograph that you can like kind of get an idea. But if you're talking like an increment of a millimeter, I mean, I guess it would depend on how close the two sizes were for me to feel confident making a choice.
Yeah. Yeah, obviously measuring it is going to give us a lot of insight. I guess I missed part of the story. Chad didn't have, because it was an image from another office, weren't able, there's no method to calibrate here, but if we had taken the image, then yes, we could measure it if the image is calibrated. So that's definitely an important part of it. But let's just say we didn't have that. Or let's just say we did. Because ultimately we had the CAT scan. That's what we ultimately ended up using, because the CAT scan doesn't have any distortion with it. So we measured it. So thank you, Elena. That was the answer. But I guess follow me, and then I think you'll understand why I was saying sometimes the measurement isn't going to be available to you. So we measured it 4.2 millimeters across. So that's the implant width. Implant width is not the same thing as platform width. All right, I think we all know that, but those two numbers are rarely the same, especially in a platform switched situation. Just because that's important, I'm going to say it again. When you have an implant width that is much wider or somewhat wider than the platform, that is platform switching. We went over that in session 17 or 18. Well, this doesn't seem platform switched because the top of the implant is very thin. So the width of the implant is very similar in width compared to the internal diameter of the most coronal section of that implant. So I knew it was Nobel active, so I went to their website and I captured this. So oftentimes it takes a little bit of investigation. Google Images is really helpful. Because the neck of the implant was 4.2, I have to assume that this is the implant that I was looking at. Well, this is 4.3, close enough. It definitely wasn't 3.5, and it definitely wasn't 5.0. These numbers down here are the implant diameters. The upper section is the platform diameter. As you can see, the 3.0 implant is not platform switched because the platform and the implant diameters are the same. Very thin coronal aspects of the implant. I don't like that for a multitude of reasons. We went over this recently with platform switching, but one of the big reasons is they're very susceptible to fracturing. At some point, we're all going to see implants fracture. You're going to see them. They're almost always with these thin-walled implants. So whenever I place an implant, I always ask myself, is the wall thick? Well, I know the wall here is thick because there's 0.4 millimeters difference between the platform and the implant diameter. The bigger the difference, the thicker the head of the implant. We'll look at that in a second. But using the tool, like Elena said, to measure, I was able to determine this is the implant itself. This is all very obvious, but sometimes with some implant companies, it's not very obvious. So I go a little further, and I said, all right, there's a difference between this implant and this implant. We have a lot of implants now have micro threads at the coronal section of the implant. Well, here there's 1, 2, 3 grooves or indentations, as opposed to the 3.5 millimeter implant. So if I come back over here, 1, 2, 3. So that gives me another clue that I'm on the right track. Again, I have to order parts for this. Like, there's nobody else that's going to help. If the implant rep for this particular company is befuddled, then we really have to think outside the box. And that's the whole point of this exercise. Another thing that I've noticed here, this particular implant has what's called a reverse taper. As you can see, there's a taper in this direction. Tapered implants are much more stable for primary stability. You're not really seeing cylindrical implants these days. Tapered is the way to go. But then there's a reverse taper at the crest of the implant. I really like this design because it maximizes how much bone you can have at the crestal part of the implant, which is the most important part. So that's an important observation. So we think we have the 3.9 platform. This is the regular platform. So if you read the catalog or the manual, regular platform RP, it's the same platform on both the 5.0 and the 4.3. That's another important point. With many implant companies, you can have similar platforms with different width implants. So if you have a 5.0 implant, sometimes the prosthetic components are the same as the larger implants and the smaller implants. Every implant system is different. It's just important to know, in the age of platform switching, the platforms are a very autonomous or independent variable for the implant. They're not necessarily tied to the width of the implant. They used to be. Used to have 5.0 and 5.0. So there's our implant there. To help drive this point home, I brought in BioMax implants. Blue Sky Bio is a clone company. They basically copy the designs of popular implants, and they are compatible with those implant systems. I've been using BioMax for many years for the more cost-conscious patients because the price point of these implants are a fraction of the cost of many of the major companies. The point being that this particular image is just very helpful for us to see what happens to the implant thickness as we go from a narrow diameter implant to something more wide, but maintaining the platform. So we see here NP, NP, NP. The upper number is the size of the width of the implant. NP is the platform. So this is the same platform. In other words, you could use an impression coping on the 7.0 millimeter implant, and that same impression coping would fit on the 3.0. This is rather unique to this implant system, and it's a reason why I like the implant system, because it made the prosthetics very easy because there was no guesswork. It was the same impression copings every time you placed an implant. Now what we can see how the thickness of the implant increases. This is a greater platform switch. Platform switching, another way to describe it is the coronal section of the implant is thicker. Okay, because the micro gap is moved more internally. Again, revisit that platform switching conversation if you're interested. Now, if we come over here, for whatever reason, Blue Sky Bio was getting a lot of their customers requesting that they had the regular platform just like Nobel. So they came out with what's called the dual platform system where they added the regular platform implant to it. So I'd never used these. It's really the same implant, just with less platform switching. Personally, I love this guy right here. Anybody have any questions about this while I bring in somebody? All right. So we've now identified that this is a regular platform Nobel Active implant. What parts do we need? I guess I put this before the treatment plan. We'll come back to this guy. Well, let's go back. Let's talk about the treatment plan. The goal of the conversation was for us to solve the fact the guy has a missing front tooth. Now, when Chad first reviewed the CAT scan, he made the observation that there's a rather large abscess in number 8. Well, we could just remove number 8, but what are we concerned about if there's a rather large... Sorry, thank you. Number 9. So what are we concerned about if we remove number 9 with a large abscess? And we don't...
Like a fenestration or something.
Yeah. Fenestration, very large defect. You know, what we might be left with because of all of that is inadequate bone. If we have inadequate bone, then we have inadequate soft tissue. Maybe the patient has high aesthetic demands. We might want to consider doing something to avoid that tissue collapse. So when we see a large abscess of a severely compromised anterior tooth, we have to ask ourselves the question, what is this going to look like when we take this out? Based on Chad and I's conversation and the conversation with the patient, we're really concerned that this is going to collapse dramatically for a multitude of reasons. It's very possible that there's a fracture somewhere in here from the post. That's why the thing came out. We do see the abscess comes up to about the level of the post. Whenever we see an abscess that is at the same level of where the post went, 9 times out of 10 you have a horizontal fracture, which may or may not be evident. There's general swelling of the soft tissue. This tooth is actually sitting outside the alveolar housing. So there's lots of reasons for us to predict that when this tooth comes out, we're going to have a significant soft tissue collapse. Patient's concerned enough that he wanted to know what his options were. We never want to pull a tooth until we have the final plan. Well, we also have this situation going on where we have bone loss around the implant. We're going to get to the CAT scan. I'll show it in a second. But let's just say the bone on the facial of this implant is not great. So I definitely think there is concern about the health of this implant. That's important for a multitude of reasons. But I'm going to share the reason that I found through some very unfortunate circumstances when I had similar cases like this. When we remove this tooth, because there's bone loss here and there's no facial bone here, this bone right here is not going to have a reason to live anymore. Guess where that bone's going to go? It's going to go right here. So if we lose 2 millimeters of bone because the PDL is no longer supporting the presence of that bone, where's it going to drop to? It's going to drop to the level of the more apical extent of the bone in that area, which is right here. All right. So when we lose all that bone, guess what? We're going to lose soft tissue. Well, what might happen is this whole implant is going to become exposed. I've seen it happen. It's really unfortunate. If this was a healthy implant, I wouldn't be concerned, but this is not a healthy implant, or it's a guarded implant. So we have to think down the road. If we take this guy out, what might happen? So,
Hey, Doc.
Yo, Jordan, go ahead.
How are you having conversations with the patient about, this type of scenario, who maybe 5 years ago spent a bunch of money on an implant, and now, you're advocating for another one, maybe 2 implants, or, yeah.
Yeah. Yeah, it's a great question. I know you know the answer, and I love that you're asking the question, but it comes down to this guy right here. You know, in my opinion, this implant didn't fail because it's an implant. I think that's what you're asking is, this patient might be gun shy to do another implant if an implant failed. Well, hopefully, and I know Chad did a great job of this because I saw how he handled the treatment plan workup. He talked about this tooth failing because of the loss of posterior support and the deep overbite, and at the same time brought the patient's attention to what the patient was unaware of, a problem right here. So Chad tied in the fact that this front tooth was probably lost due to loss of posterior support and a deep overbite and entrapment. So the unfortunate trifecta of anterior tooth demise. So he used that to paint a picture of, you have a problem with your implant, but it's not an implant problem. It's a systemic problem. So I think the important part of answering that question comes down to coming back to the environment that implant was living in. With that said, that implant's still stable. So it's important to say, an implant that's stable, that has biomechanical stress on it, is very different than an implant that failed due to biological reasons. This is 100% a biomechanical failure, or potential biomechanical failure, and not a biological one. So I would also paint the picture to the patient that this is a little bit different than a failed implant. It's just this implant's been sitting in a very stressful environment, and we are advocating to upgrade that environment so that your implants, that whatever implant situation we have in the future, doesn't sit under those stresses.
I like it.
Yep. Anything you want to add? Because I know you and I have had several similar cases.
Yeah, no, I mean, just driving the point home, even, to the patient, even given the strong biomechanical duress that implant's been under, again, stressing the fact that it is still stable, but biologically,
Right.
It's not in the greatest situation. So if we fix the biomechanical factors, you can only imagine how, long our potential implant could last, and then accounting for all those.
Yeah. Thank you, Jordan.
Mm-hmm.
Yeah, I mean, how we talk to patients is everything, so asking these questions during these treatment plan conversations is very helpful. Your question brings up a valid point. Maybe we don't need to do anything with that implant. Maybe it'll be okay. Maybe there's a biological compromise, but if we improve the biomechanical duress that it's under, maybe the implant survives. I've definitely seen lots of implants like this that have been that way for many, many years. I have five implants I can think of off the top of my head that have seen the periodontist every 6 months, that quote unquote are biologically compromised. They're not bleeding on probing, so that's important. There's a whole separate conversation there. But just because you have bone loss on the CAT scan and the PA doesn't mean it's a failed implant. It's just concerning. And I think Chad definitely did a good job of getting the patient to understand, hey, if we touch number 9, that's the whole point of this. If we touch number 9, number 8 might become a lot more evident because of the fact that this bone right here is going to drop down. The tissue is going to drop down with it. These threads might become exposed, which is going to introduce a aesthetic and then a potential greater biological problem, because plaque buildup around threads is always an issue. And then we have the fact that the facial bone is gone. Well, if there's no bone on the facial, we know that bacteria can run right down this. So the reality of it is, by removing this tooth, we might condemn this implant. We might not. So we're going to go into this with the patient being aware that that's a reality. And I believe Chad has articulated that with the patient. And it might be a reason why he hasn't gone down the more comprehensive road, because this was so convoluted. It was difficult for the patient to wrap his head around, okay, I have this in the front, and you're talking about all this stuff in the back. So Chad, do you want to shed any light on this particular area? I know number 3, the patient has agreed to socket preservation and a future implant. But where's his head at with this particular scenario on 8 and 9?
Yeah, I mean we've talked at length about it. That being said, I feel like he's someone who like we've been kind of going at this whole process for a while now. I feel like I almost need to remind him, just to kind of make sure that we're all on the same page. But I've definitely talked about how delicate this whole area is in the front. It's
Yeah.
very unpredictable no matter what we do, but we have to do something because of the abscess, because of how it's broken through that buccal plate. Like we have to do something. So this is kind of our best attempt to save what we can with the area.
Yeah. So to fast forward to the treatment plan, what Chad and I had come up with is the following. We're going to disassemble, or Chad's going to disassemble number 8, so we can get a future cantilevered pontic. The pontic being number 9, the retainer being number 8. The implant's stable, so there's really no reason we can't do that. We're going to have to build the occlusion somewhat differently, so that we don't put as much stress. We don't want to overload this already quote-unquote loaded implant. With that said, there's really no other option here other than, a partial denture or a flipper, which the patient wasn't interested in, or some sort of tooth-borne option, which the patient wasn't interested in. So the treatment plan is to remove this tooth, do some socket preservation. It's actually going to be a ridge augmentation. It's going to be a much more advanced version of a socket preservation because of the fact the entire buccal plate is fenestrated, like Jason said. Fenestration is essentially loss of the buccal plate. That's going to be a very predictable graft, but it's going to be one that's going to require a full flap, quite a bit of time, degranulation, some xenograft material, which is a longer resorbing material. So there's lots of different things we're going to have to do to build this up, and then let it sit for 8-9 months. And at that point, we're going to watch what's going to happen with this bone and then see what happens with the soft tissue around this. In the meantime, we'll have a temporary implant, a implant retained provisional cantilever coming off here. So that's the treatment plan we came up with, but I wanted to talk through a pretty important part. Chad and I were talking this morning, and I was like, man, this is such a good one. We have to talk about this. So when disassembling an implant crown, it's good to know the following. Is it cement or screw retained? We often don't know. If we can't get the information on the implant itself, we probably don't have the information of whether it's cement or screw retained. Which cement was used? Was it a permanent or temporary cement? What was the buccal and lingual angle of the implant? Or how do we determine that angle of the implant? Super important. Before I go there, these are important things for us to determine. How are we going to go in and get this thing apart? If it's a cement retained and they use temporary cement, then we just pop it off and then we get the custom abutment, and then we take off the Teflon tape, unscrew it, and we're good to go. But it's not ever that easy. So buccal lingual angle determination. I'm going to skip to this because I want to show the CAT scan image. We really have to know this. This particular angle now tells us that this was either a screw retained or cement retained, but it also tells us where we need to go in order to get to it. I've had many situations where I didn't know the answer. So a patient shows up and I have this right here. By the way, this tells us that this is not a screw retained because we don't see a screw access hole. It's very possible that the composite is extremely well matched, but I don't think that's the case. I think we can all agree that this was a custom abutment and then a cement retained crown for a situation that would have benefited greatly from a screw retained, because the axial inclination of the implant emerges through the lingual of the crown. This would have been perfect for screw retained, but neither here nor there. It might have been done during the era where screw retains were not done routinely. The angle of the implant is important because it tells you where to go into the tooth. Now, this particular implant, we'd probably get lucky because we would most likely go here and keep drilling until we hit Teflon tape, cotton pellet, so on and so forth. But oftentimes the angle isn't as favorable as this. Many times the the bone in this premaxillary area is somewhat tilted. The implants are rather tilted. We just don't know because we're not going to tell on a PA, and we have no other way of telling if we don't have a CAT scan. So that's why I put here, there's different ways of finding out the buccal and lingual angulation. I was up in Naples working at that practice, and the doctor who had once owned the practice actually drew a map of the angle of his screw access channels so that if he ever needed to go back in there, he would know the angle. Super, super, super cool. Never seen that before, so I call it mapping. Something to consider. Save some future dentists a huge headache if you're doing a cement retained situation where you're going to use a permanent cement. The other way to tell is lots and lots of burrs in time. I've spent hours trying to find the screw access channel in situations where it just wasn't that easy. And then lastly, the cone beam CAT scan really helps us. So when disassembling, I guess we already went through that. This particular situation, Chad's just going to go in. He knows the angle. He's going to look at this image here. He's going to get some sort of reference point, maybe the facial of the crown, and then he's going to angle accordingly. And he's going to go until he hits something. It's going to be air, Teflon tape, PVS, cotton, Cavit. There's another Fermit is a common one. So there's all kinds of different things that he could run into, but you have to know what you're looking at when you get in there. So very good illumination when you're accessing a crown and you're trying to unassemble something like this. Good illumination, good magnification is super important. So here we come back to the facial bone loss. There's just no bone on the facial of this implant. There is soft tissue, but soft tissue is not as stable as having good bone, good vascular bone. So another thing we see on the image is the deep bite. So we can see if we measured from the incisal edge of number 8 to the incisal edge of 25 or 26, that's rather deep. That's a good 4 millimeter, 5 millimeter situation. We can't really tell entrapment here, but you could probably draw the conclusion that there is entrapment here. Entrapment is essentially when these lower teeth, the teeth sitting on the mandible, want to be more forward than what the upper teeth are allowing. That's what we call entrapment. We know there's entrapment because one of the images showed articulating paper marks on regular occlusion. So evidence here, and I do think the entrapment has a lot to do with why there's many issues here. Loss of posterior support. You don't see that on this image, but I put that here anyways. And then anterior guidance. Is this a steep or shallow anterior guidance? Anybody want to take a stab at this?
Looks pretty steep.
Yeah. So that would be shallow. That's steep. When we talk about anterior guidance, it's important for patients that have loss of posterior support because it's very common that their muscles are very hyperactive when they go into protrusive movements. We're going down that ethology road again, but it is part of our decision making, so let's bring that in here. This patient, for a multitude of reasons, probably does not have the proprioceptive reflex that most people have when their masseters and other elevator muscles turn off during protrusion. So again, if you were to bite on your front teeth and try to flex your masseter, it's not going to flex that much. You bite on your back teeth, your masseter flexes. That's a peripheral nervous system reflex that's built into our system to protect our front teeth. Well, there's a certain percentage of the population, this guy being one of them, where that doesn't exist. We know that because he's broken his front teeth. You just don't see that in people who have that reflex well established. The reason I bring this up, patients who have that, you want to shallow their guidance out. It's just that much more important. Now, we could just look at his teeth and say, okay, this guy's destroyed his teeth, therefore we should shallow the guidance. But I think it's important to understand why we're doing or making that decision. Anybody have any thoughts about anterior guidance design and how it plays a role in treatment planning? So Jordan has that awesome case, Mr. Wan. He had a very similar situation. Jordan solved it by opening his bite. So you can shallow the lingual surfaces of these upper anteriors, or you can actually open the bite, which is another way of solving the problem, which helps to shallow out the guidance.
What ways might you recommend for when you don't have that ability, like in this particular case? I mean, I know we talked about an enameloplasty on the lowers.
Yeah, that's a good question, because not every patient's going to have the wherewithal to do a full mouth rehab. The hard part is the incisal edge of this implant crown is determined by aesthetics. So if you were to extend, take this incisal edge and bring it facial, you're going to reach a point at which you just can't bring it more facial because you're going to compromise the aesthetics, make them bucky, so on and so forth. Enameloplasty of the lower might buy you some room, but it's not going to shallow the guidance. So I do like the idea of enameloplasty in the lower as a kind of triage tool, but it doesn't necessarily change the guidance. It really comes down to opening them up. Unfortunately, sometimes full mouth rehabs are often the answer to isolated problems. Unfortunately, it would be nice if there was a simple solution, and maybe that simple solution is composite on his lower teeth to open him up with a partial. So it doesn't necessarily need to be a full mouth rehab that's on the tune of $60,000. There are affordable ways of solving this problem with a comprehensive approach. But unfortunately, because of the aesthetic component of this, you're really kind of limited on how shallow you can make this incisal edge. Now, if aesthetics aren't a concern, sure, you could shorten this, shallow it out a little bit, and I do think that this patient might be somebody who would be open to that. With that said, I think it's good for us to appreciate the understanding that sometimes fixing back teeth to fix front teeth problems is the answer. All right. So this is the treatment plan. Remove the crown on the implant, temporary cantilever with number 9. Extraction of number 9 with socket preservation or ridge augmentation or GBR, whichever one of those you want to call it. We're more likely to use a xenograft material, which is slower resorbing, which is going to give us more stability long term. We're going to give it 9 months. This is not a socket preservation. Socket preservation is healed in 3 months because there's 4 walls feeding blood into the site. This is a 1-wall defect. Very, very, very different. So you have to treat it differently in how you graft it. And then we're going to assess number 8 and see what's going on. And I put Y here. We already answered the question. The Y is a loss of the bone right here. And then we're going to update the treatment plan. We'll go from there. But I think it's important for the patient to know, we're not going to give you the finish line. This is way too difficult of a situation for us to predict. Telling patients we're going to reassess at a point in time is an extremely powerful tool because it implies to the patient that you don't know what's going to happen. Patients want predictability. They want exact answers. We know better, but patients don't. So having a reassessment built into your treatment plan is a very powerful tool that I've been using recently, and it's decreased my brain damage immensely. Somebody has something?
Question, yeah. When we do the flap in that whole area, do you think we're going to see any part of the implant, or do you think there's still a shell of bone in front of that on the facial?
It's possible. It's a great question. I've uncovered many similar situations. There have been times that on the CAT scan it looks like there's nothing there, and then there is a sliver of bone. Sometimes there's a sliver of connective tissue. Yeah, we could definitely go down that road. I think it's you're safest to assume that is not bone. So I wouldn't remove, let's just say you saw a CAT scan and this guy had no problems. no, you wouldn't remove that because of what you saw in the CAT scan. But we're building a plan based upon the fact that there's a high likelihood that this is going to become a problem based on what we're doing with number 9. So I love your question. I have a friend who once placed an implant, and that's what it looked like 9 months later. The patient ended up at a periodontist, and the periodontist ended up taking it out and then ended up suing the dentist for, I don't know, placing an implant with no facial bone. And it looked just like that, but it was perfectly stable. There's a lot to that story. Basically, the periodontist actually got in trouble for saying what he said because there's no literature to support why he said what he said. So it became quite a nasty mess. Point being, yeah, we don't know. We often don't know until we get in there. But we do know it's at high risk. And if it's at high risk, we need to make sure the patient's aware. All right. So we have, let's see. I think this is an important one. Chad, you want to go over this real quick? I think this is a good one for us to go over together. So I think we're going to get kicked out. I wish I could just extend the time. All right, I'm going to see if I can pull this off really quick. All right, so this is a situation Chad did. Fabulous bridge preps, beautiful. I wouldn't have put this up there unless one, he gave me permission, or two, I'm not jealous of his preps. These look like Hicks. Very nice taper, axial, nice round corners, textbook. He did some socket preservations down here. The patient has a temporary bridge from 17 over to 20. Extremely difficult bridge to stay in place. So Chad's gone through a whole bunch of issues with this. Chad and I talked about this morning. We went through things like individual prep forms. These individual preps are great. The grooves, would grooves have helped? Relining the temporary so that it's very, very taut on the teeth. But I wanted to go over this concept here, path of draw. So Chad took an impression, sent it to the lab. The lab sends it back. The path of draw here is the issue. Chad, I promise you I've done this a billion times. So as I'm saying what you could have done better, do know that I've definitely been there. And I think everybody on this call would agree that
lay it on.
We're here to learn. So how do you tell if two preps are parallel to each other? Occlusal mirrors are really helpful for that. Occlusal mirrors, the mirrors we use for taking an occlusal photo. And what you're looking for is you want to see the margin all the way around on both teeth from the same angle. Very similar to us putting a partial denture cast on a surveyor. We want to make sure that there's a path of draw. Well, the lab made it anyways, and most likely because the path of draw wasn't there, they counteract that by creating a very, very large intaglio to fit over it. And my thought is that intaglio, that increase in volume of the intaglio, is the reason why this kept coming off. So what Chad's going to do, he's going to leave this guy here. Let's go here. Keep number 20 as is. He's going to add composite to the facial of 17. Prep the lingual of 17 so that they're parallel to the lingual of 20. He's going to add composite so it's parallel to the buccal of 20. Make sure that the mesial and the mesial, distal and distal line up, so on and so forth. Then add a couple anti-rotational grooves. We took a look at her occlusion, and we're thinking that this is popping off laterally, so putting a Hicks-styled mesial and distal groove here, I think would provide a very, very favorable situation. And then reline the FPD using the spear technique, which we've gone over. Happy to share that if anybody's curious. And then lastly, using the hand test for provisional retention. This is something I came up with recently. If you can take a temporary off with your hand, use Duralon. If you can't, you can use regular temporary cement. With that said, Chad's goal is to get this so that it does stay on, and when he goes to take it off with his hand, it doesn't come off. He has to use the temporary crown removers, at which point in time he can tell the patient, we finally gotten to a point that this isn't going to come off in an hour, hour and a half. So I thought this was really, really insightful. I mean, Chad, you and I have looked at this many times. It was only after repeated falling off that this became obvious to me. So thank you for letting me share this. The whole goal for this is for us to share our struggles.
I've been thinking about this also today. If I add composite to the facial of 17, I'll have to relieve that on the intaglio of
Correct.
the crown, correct?
Yep. Great thought. The other part of this is you've got to be careful of the pulp here. I don't know how close to the pulp you're going to get, but you just want to be careful of that. Yeah, great case. The occlusal mirror for pathodraw for bridge design. Great tool. This might be hard because this tooth is so far back there, you might not be able to get the mirror there, but at least you have some sort of idea. Plus, you can use the scanning. You can use the Anterior to help you with it. Just wanted to share this. This was a crown that Regan had delivered on number 8 recently. Cost-conscious patient. He used Glidewell and was able to get that result. High lip line, patient's ecstatic. So with proper lab communication, you can get pretty good results with Glidewell. You just have to get really explicit as you are telling them where to put the different shades. So again, this is zoomed way in. We could pick this apart like any sort of zoomed in anterior crown, but this is a beautiful outcome for the patient. Alrighty. So in conclusion, implant prosthetics can be difficult. Always remember the hand method to provisional retention determination. Organized dentistry needs help. Reach out if you have any interest. And the Patriots are playing, so I am going to bed, or going to watch TV. Thank you, everybody, and we will see you next week.
Thanks,
Thank
Doc.
you.
Thank you.
Take care.
Yep. Thank you.